Hello, everybody. My name is Ian McLaughlin, and I have a PhD in neuroscience. And today I want to talk about a study that was published earlier this year out of one of the leading research institutions in the world, which explores a new potential treatment for depression. And so my own research focused on trying to identify some of the specific neurons in the brain that encode anxiety and addiction. And let me tell you, it's a complicated web of neurobiology. There's no specific part of the brain that causes these maladies. It's a complicated combination of life experiences and genetic inheritance, and as a result, the effort to develop effective treatments for these kinds of conditions is among the most challenging in biomedical science. And so to give you a sense of at least one reason that depression is really a dire concern, and I apologize that these data are US-centric, but according to stats from the Centers for Disease Control and Prevention, or the CDC here in the United States, these are the 10 leading causes of fatalities in the United States from just 2 years ago. So if you just focus on the green boxes, I know there's a lot going on here, but just focus on the green boxes, with the age groups increasing from left to right, starting at just 10 years old, individuals taking their own lives is the second highest cause of loss of life. And that's the case all the way up until people are 34 years old. And as people get older, it remains one of the top causes of life, or loss of life, until people are well into their 60s. And people have been taking their lives more and more over the past decade, again, according to CDC numbers. Now, I know I'm sort of obnoxiously being focused on the US, but according to the WHO, 1 in 100 fatalities worldwide is due to someone taking their own life. And so, to be clear, depression, of course, isn't the only cause of people doing this. The majority of individuals confronting depression don't do so, right? And the statistics are obviously complicated. Regardless, depression is a life-threatening condition, and it can cause, it can result in tragic outcomes. And so, while we're fortunate to have several strategies to confront depression, the efficacies of the treatments leave quite a bit of room to be for improvement. Due to issues like side effects that affect quality of life, as well as just levels of efficacy that could just be higher for a variety of reasons. And so before I get on my soapbox about why we don't already have more effective medications, let's get to our study for today. So pharmacology nerds might already have a sense of the subject that I'd like to discuss today. But I think it's worth noting that this was published in the New England Journal of Medicine, or the NEJM, which is one of the most widely read medical journals in the world. It's literally one of the top 3 most widely read journals that publishes biomedical research in the world. If a study is published in this journal, essentially every scientist and physician who's interested, at least in this domain of biomedical science, will read it. Not only that, but this is a group out of Imperial College London, one of the top neuroscience institutions in the world. And not only that, but one of the authors of the study served as an advisor to the Ministry of Defense, Department of Health, and Home Office in the United Kingdom, Dr. David Nutt, a fairly world-renowned neuropsychopharmacologist who's been one of the most scientifically courageous investigators worldwide. So in other words, this study has all of the ingredients of an absolutely exciting bit of science. So let's dive in. So this was a double-blind, randomized controlled trial. So what does that mean? First, double-blind means that both the patients and the researchers have no idea which patients are receiving which treatment, or particularly the treatment of interest. And so the researchers provide a treatment to one of the study participants, and they have no idea if they're providing a sugar pill or the thing that they're actually studying. Okay, next, what does randomized mean? So, it's probably a little bit more intuitive than double-blind. There's just nothing that determines whether a study participant gets a sugar pill, placebo, or the treatment of interest. It's purely random. And so I've said sugar pill, I think 2 times. So a sugar pill is basically a sort of informal term that's used to refer to a placebo, right? A treatment that has no meaningful biological effect in, the thing that the scientists are studying. But in a study like this one, we're actually not comparing a treatment to the absence of a treatment. We're comparing it to the standard treatment that already exists, right, before the study. And so, we're comparing an antidepressant called Escitalopram, or Lexapro, to a far more infamous molecule. A molecule that's produced by an entirely separate biological kingdom fungi, or fungi. It's a molecule called psilocybin. So, I know in the thumbnail I have Prozac, which is fluoxetine, not escitalopram. But their pharmacologies are just about the same, and I suspect far more people are familiar with Prozac than they are with Lexapro. So anyways, I've gone into the pharmacology of psilocybin in the past, and so, let's not dwell too long on those details. But I think if we just take a look at the shape of a neurotransmitter with which you might be familiar, serotonin, I think you'll get the picture. And so, I know looking at chemical structures isn't particularly edifying, right? But just look at two things, two features of these molecules. We have a hexagon right next to a pentagon that has an NH, right? And then a wiggly tail, with an NH at the end, right? They both have that. But there are some, very important differences beyond those similarities. But fundamentally, these are rather similar molecules. And so as a result, psilocybin can do a lot of the same things that our own serotonin can do, notably bind the same neurotransmitter receptors that serotonin binds, but can also do a few additional things, interacting with various targets in the brain in ways that serotonin doesn't, and even, changing the way that serotonin itself behaves within the brain. And so many parts of the brain that serotonin influences and regulates, which is a very wide range of aspects of our consciousness and our experience, things like emotional states, appetite, memory, and maybe most infamously our sensory systems like vision, our auditory system, and so on. Those systems can be influenced by a molecule like psilocybin. And so it's a molecule that's sort of wearing a serotonin costume. Right, so psilocybin is probably one of the most well-known molecules among people outside of neuropharmacology and neuroscience who have at least an interest in altered states of consciousness. However, and I realize many folks aren't necessarily in that category, right, and might hear about this molecule due to a journey to find a better treatment for depression rather than just an interest in altered states of consciousness. So broadly speaking, this is a molecule that's found in a variety of mushrooms. And so here are a few of them. You're seeing cubensis and Silenziata in the middle. So cubensis at the top, Silenziata in the middle, and then Hollandis at the bottom. Those are truffles. Well, they're actually not technically truffles, but these two are some of the more common ones that are found and people consume. But there are many dozens of types of mushrooms that produce this molecule, psilocybin. Even some that grow similarly to truffles underground, right? And so briefly, the effects of psilocybin are pretty complicated. Remember that serotonin signaling influences a ton of different aspects of our consciousness and our experience, and as a result, the effects of a substance that interacts with that signaling system, with the serotonergic signaling system, will be similarly diverse. And so, probably the most well-known effects of psilocybin are its visual effects, right? But I think that there's a misunderstanding regarding how it affects vision, because at least some people assume that, because it's a hallucinogen, a psychedelic hallucinogen, it causes people to see completely realistic things that simply aren't there. They expect that you might see a totally realistic cat just walk across your screen, right? Or, you might have conversations with people who aren't there just as though they really were there. That's not exactly how it works with this category of substances, at least at the doses that the vast majority of people take. Rather, what they do is they sort of distort existing visual stimuli. So, straight lines might begin to get a little wavy or wiggly. The walls may bend in and out a little bit as though they're breathing, right? You may begin to see patterns on things like a textured wall or a popcorn ceiling or something like that, or in the clouds that aren't actually there. And so, colors can become more striking. If you're looking at, some wood or something like that has those sort of natural variations and patterns, they can begin to sort of drift a little bit. Facial perception can be altered, where you become sort of strangely hypersensitive to certain features of the face. Facial expressions can be, similarly like amplified or magnified or at least altered in some ways. It's things like that, right? You're not just completely seeing things, or you're not seeing things that are completely realistic that aren't actually there. That's associated with a different category of substances called deliriants. And so the visual effects are really only one part of the repertoire of effects that this substance induces. So time perception can be dramatically altered, where 5 minutes can feel like 2 hours, or 2 hours can feel like 5 minutes. Emotionality can be affected, where you begin to have emotional experiences induced by like sensory stimuli that wouldn't normally elicit such reactions, right? Like looking at a piece of art, listening to a song, revisiting a memory. Essentially any conscious experience can elicit sort of strangely magnified and volatile emotional experiences that wouldn't normally happen. And, there are a ton of other effects of the substance, effects on things like cognition, like the thoughts and associations between ideas that you experience, on appetite, on olfaction and gustation, or a sense of smell and taste, as well as, how all of the senses interact and influence each other. But just for today, it's the molecule's effect on emotional states and something called suggestibility that are most important when it comes to the treatment of depression. And so suggestibility refers to a state of consciousness where people they become more receptive to interactions with other people. And in the prospective application of psilocybin as a treatment for depression, more receptive to the therapy delivered by an experienced therapist. And so I've talked about the prospect of Mdma, another infamous substance that's actually a bit further along in the process of, likely becoming a medication that can be prescribed for the treatment of, psychiatric conditions. And so, probably the central therapeutic effect of Mdma is that it amplifies suggestibility, making people who've experienced severe trauma and will tend to be, therefore, sort of closed off and wary of interpersonal interaction. The substance helps them to open up a bit and be more receptive to the input of a therapist. And so I've linked one of the more recent discussions I've had of MDMA down below. So anyways, there's a similar theme going on here with psilocybin. Enhancing suggestibility seems to put people in a state of consciousness that just amplifies the efficacy of therapy, which can be extremely helpful when trying to treat or live with a psychiatric condition like depression or PTSD, which are extremely difficult to treat and for which we have few effective treatments. Okay, so when it comes to psilocybin, there have been several clinical trials to explore whether psilocybin might be useful for the treatment of depression and anxiety, already conducted in the past. At the time of this video, there's been one open label trial, which means that everybody, including the patient and the clinician, knows who's getting psilocybin, right? That's open label. And then there's also been 4 randomized controlled trials of psilocybin for the treatment of psychiatric conditions. So this isn't the first, right, clinical trial. But generally speaking, these trials have demonstrated reduced symptoms of depression after 1 or 2 doses of psilocybin. And so this group was inspired to conduct their own clinical trial. And so this group did a phase 2 double-blind randomized controlled trial, okay, with individuals who had moderate to severe major depressive disorder. And they were comparing psilocybin to one of the more widely prescribed antidepressants, Escitalopram, right, which you might know as Lexapro. And so, to be clear, like this is basically the gold standard of clinical trials. It doesn't get much more rigorous than a trial that's double-blind, where neither the clinician nor the patient knows whether the patient is receiving the experimental treatment. That's also randomized, where the collection of patients who end up receiving the experimental treatment is completely random and not based on any selection criteria. Like, for example, one selection criteria might have been only people who've had past experiences with psilocybin so they know what to expect would be included. So they didn't do that, right? It was just completely random. And where the experimental treatment, psilocybin, is being compared to a medication that's really one of the frontline treatments for depression today, right? Escitalopram or Lexapro. So pretty great, okay? And so I said this is a phase 2 clinical trial. And so, the clinical trial phases can get a little Byzantine, but at its simplest, phase 2 is when a medication has already been evaluated for safety in humans. Questions like, does this molecule kill people, right? Does it cause obvious damage to an organ system, like the liver or the heart or the brain, right? Those questions have already been addressed. It's most definitely already undergoing testing in the kind of lab settings in which I worked, right? Preclinical. That's where the basic biology of the medication is established. What does the molecule do in the body? What receptors does it bind? What enzymes does it influence? How does it influence the behavior of animal models like rodents or non-human primates before it's tested in humans? And so phase 2 is where we add quite a few more people to the trial. Okay, rather than just a handful of people who are valiantly volunteering to be the first to test out a new possible medication to see if it has any negative reactions, we're talking about a few dozen people. And the question extends beyond whether the molecule is dangerous. We're now curious about whether the molecule might become a medication, right? Whether it might be an effective treatment for any given condition. And so this study was conducted in the United Kingdom, so there may be some slight variations in how that works, in the UK versus the US. Obviously, I'm most familiar with how it works in the US, but generally speaking, they're likely very similar. Okay, so once again, we're working with patients who've had long-standing, moderate to severe, major depressive disorder, and they were comparing psilocybin to Escitalopram, Lexapro, and they did it over a 6-week period, okay? And so when it comes to who the patients were, they enrolled both men and women, 59 altogether, between the ages of 18 and 80. So it was quite a range. Though the average age of the participants was 41 years old. Okay, and they found them through, the sort of standard clinical trial awareness pipelines, physicians recommending it, to that, that kind of thing. But then they also use social media and other sources, is how they include that in their paper. And so all this led to the prospective participants to their website, right, visiting their website. And so when it comes to how long they'd been diagnosed with depression, the folks who ended up receiving psilocybin had been diagnosed with depression, formally diagnosed, for an average of 22 years, while the Lexapro group had been for an average of 15, okay? It would be interesting, just as an aside, to know what other sources they used, because, if they were relying heavily on social media, you have to wonder if they were selecting for a certain kind of individual who's fairly internet and social media savvy, right? That they would even think to look, or they, would even be, become aware, right, that this clinical trial was even going on. Just particularly given the fact that they included folks who are, a bit older than your standard social media savvy millennial, right? Not a big deal necessarily, but it would just be interesting to know. Definitely not a big deal though. So, like all clinical trials, there were exclusion criteria. That's true for every clinical trial, which means that the characteristics that someone might have that would make the researchers decide not to include them in the study. And so, frankly, I think the one that they applied is totally justified. So they didn't include people who had a history of psychosis, significant, other health conditions, a history of suicide attempts, a positive pregnancy, a positive pregnancy test, any contraindications with taking an SSRI, like if they're on other medications. After all, some of the participants were going to be taking Lexapro, right? Previous use of Lexapro, or a history of another psychiatric condition like borderline personality disorder. So, I won't go into why I think all of those exclusion criteria are totally justified, but the main point to keep in mind is that when it comes to clinical trials at this stage, the goal is to test a very specific molecule under very specific circumstances, right? The question isn't, is psilocybin ideal, an ideal medication for everyone who's been diagnosed with depression, right? That's not the question. The question that they're asking is psilocybin safe and effective for someone diagnosed with moderate to severe depression compared to a standard treatment for depression? That's the question. And so, as a result, you want to make sure that the folks who participate in this study, they wouldn't pertain to a different question, right? Like, is psilocybin safe and effective for the treatment of someone who's been diagnosed with depression and bipolar disorder, or for someone who has a history of psychosis, right? And so the molecule may well be just fine for folks with more complicated psychiatric backgrounds than just being diagnosed with depression. But, this is one of the early hurdles that a molecule has to pass to become a medication. And so it's always important to make sure that the assessments of the molecule are very specifically targeted, right? You want to set yourself up to succeed in even having a chance to effectively ask your question, right? So the group didn't exclude people who did have prior experience with psilocybin, right? So in other words, some of the participants likely knew what to expect when it comes to psilocybin, right? Some of them didn't. And so I don't think that's a massively significant, confounding factor, that would compromise the entire study or anything. But when it comes to the effects of a substance like psilocybin, which very dramatically alters a person's state of consciousness, way more than, Escitalopram or Lexapro, there's a pretty big difference between knowing what to expect and having zero expectations whatsoever. But anyway, so they also had all the patients undergo fMRI tests and functional magnetic resonance imaging, just essentially a brain scan, and then a whole series of tests to evaluate their cognition and their emotional status. And they also had an initial therapy session to prepare for the big day, right? And so on the big day, the patients who received psilocybin were given 25 milligrams, which, to be clear, is a pretty serious dose, right? So dosing when it comes to this substance in particular is pretty tricky. So, remember how there's tons and tons of different types of mushrooms that produce psilocybin, right? But, the tricky part is that they don't all produce the same amount of psilocybin. Some produce far more than others. Some are far more potent than others. And of course, some mushrooms are just larger, right, than others when someone receives them, right? And so, a lot of the folks who are experienced with this substance via the mushrooms themselves will focus on the weight of the mushrooms, not the actual dose of psilocybin within the mushrooms, because it's not like you can see that, right? You can't weigh it and know how much psilocybin is inside a mushroom. But broadly speaking, 25 milligrams of psilocybin is a dose that will induce pretty substantial hallucinogenic effects in most people, okay? So, on the big day, the participants received their psilocybin while listening to a specific playlist of music. And actually, I meant to check to see if they actually published what the music was, that playlist. That's always interesting to me. And a past study that I talked about did publish their playlist, which is pretty cool. But anyways, so they were listening to this curated, playlist of music, and then they were also being guided by a psychological support team. And, to be clear, the team was present for both psilocybin and Escitalopram Lexapro groups. So, interestingly though, the group of folks who ended up receiving Lexapro also received 1 milligram of psilocybin, which, and everyone was told that they were going to receive psilocybin, which is, probably why they provided that 1 milligram, which is, 1 milligram is expected to have minimal effects, if any, at least, noticeable subjective effects, right? And so, so everybody got some psilocybin, but some got way more than others, right? And then they also had trained mental health professionals on hand for each of the dosing days, and everyone was told to take a capsule every morning. Everybody was taking a capsule every single morning, and the capsules contained either Lexapro or cellulose, which is what the psilocybin group was given, right? So everybody was doing essentially the same thing. Everybody was told that they were going to get psilocybin. Everybody was taking a capsule every morning, but some of the capsules contained cellulose or sugar pill, and some contained Lexapro, right? Okay, so then the second dose of psilocybin was given 3 weeks after the first dose, okay? And then patients were evaluated the next day after that second dose. And so everyone then came back to be evaluated once again 3 weeks after that, where they did all kinds of tests to get a sense of where everyone was after all the treatments. Okay, so how did they judge if people actually improved, right? So the scientists used something called the Quick Inventory of Depressive Symptomatology Self-Report, or QIDS, KIDS, I guess. So it's KIDS SR16. That's like the technical name for the test that they use, which, and so you're seeing an example right here. As you can see, it's sort of a simple set of questions, right, that someone answers to get a sense of how their symptoms of depression may have changed over time, right? And the test touches on all the main features of depression that are, described in the primary manual of psychiatric conditions that's used, at least throughout the United States. There's an equivalent in outside of the United States it's very, very similar. Okay, so they all took this test, right? So here's what they found. Let's get into it. So, simple graph. Nice, right? The blue line is the Lexapro group, the Escitalopram group. The red line is the psilocybin group. And we're looking at their QIDS KIDS score of, that survey of depression, how it's changing over time, right? Starting from when the first psilocybin dose was administered, okay? And so, as you can see, the KIDS score, that's the test to use to get a sense of where people are with their symptoms of depression. It's persistently lower in the group who received the major psilocybin doses. And so when it comes to this test, lower numbers, lower scores equates to, or they equate to less severe symptoms of depression, okay? So what these data are indicating is that their own sense, the participants, the patient's sense of their state of mind had improved more than the group who was receiving their daily Lexapro. Very interesting. However, when it comes to this kind of science, right, we run statistical tests to get a sense of just how significant these differences really are. They may look significant. They may intuitively seem significant. But we run these statistical tests to get a sense of, is it possible if these two groups are essentially responding equivalently, largely equivalently, but it just so happens that the group receiving psilocybin in this specific iteration of this specific clinical trial, in this moment in time, they just tended to experience reduced scores on this, test of depression symptoms, but in a future study, they might just as likely see the opposite results, right? That's why we test for significance. And so it turns out that there was no significant statistical difference between these groups. Okay, there's clearly a trend, right? But no significant difference, at least when it came to this QIDS score, right? This survey of depression symptom score. Okay, so did they do anything else? They did. So in addition to that QIDS, survey test that they conducted, they had the participants go through a variety of other tests. One of which was the Warwick Edinburgh Mental Wellbeing Scale, or WEMWBS. No fun acronym there, but as you can see, you can see some examples of the types of questions that are on this test. And so it's basically another way to do the same thing that the QIDS test does: get a sense of how people are doing by asking them questions about how they're feeling in various ways, right? And so here's what they found. Oops. Sorry about that. Okay, so here's what they found. Same colors again. The Lexapro Escitalopram group is in blue. They're the blue line, and then the psilocybin group is in red. And so this is how they responded to that WEMWBS test, that other survey sort of test, over the course of a bit over 40 days. Okay, and so keep in mind, as opposed to the QIDS score, higher scores on this one indicate improvements in mental well-being. Okay, and so once again, looking pretty good, right? But once again, they were unable to identify a statistically significant effect of psilocybin. Okay, and this was due to how they conducted their statistical tests and conducted their study. COVID-19 did have a bit of an effect on their ability to conduct this study. But so we see a trend once again, but there is no statistical significance. Okay, so where does this leave us? Fundamentally, we can't say that psilocybin is more effective than escitalopram or Lexapro when it comes to treating depression, right? It certainly looks good, right? And we certainly can't say that it's worse than, daily treatment with Lexapro for the treatment of depression, right? But the data don't indicate that it's better either. That said, and so, take that how you will, right? That's not necessarily bad news if you're very interested in seeing psilocybin being deployed as a treatment for depression. So it's certainly not the kind of news that I suspect anybody would want to see. But it's also not bad news for somebody who's interested in moving psilocybin into becoming a medication for psychiatric illnesses, depression specifically. But so, that said, selective serotonin reuptake inhibitors, a category to which escitalopram belongs, Prozac, fluoxetine belongs, pretty much any antidepressant you can probably name is an SSRI, a selective serotonin reuptake inhibitor. So, when it comes to that category of medication, they're sort of fairly notorious for their side effects. So when it came to things like dry mouth, reduced emotional responsiveness, and sexual dysfunction, the participants who received escitalopram reported higher rates of those than the participants who received psilocybin. And so the group also noted that 4 patients who were receiving escitalopram stopped taking their daily dose altogether due to perceived side effects, and one of the participants cut their dose in half because they felt like they were experiencing negative effects. And so the group notes that no one in the psilocybin group wanted to avoid their second dose. Right? They had their first experience. Everybody definitely knows what to expect for the second experience, despite some of them, already having known what to expect before the first one because they had prior experience with psilocybin. And nobody dropped out, right? Though they did lose 3 participants on the second dose due to limitations induced by, or imposed by COVID-19. 2 of whom were in the psilocybin group, and 1 of whom was in the escitalopram group. So, they lost some potential data there. But okay, so where are we now? So what we're seeing is a pretty meaningful improvement in depression scores among the group who received psilocybin, right? Just not statistically significant. Not statistically significantly better than Lexapro. But they did see an improvement in depression scores in 70% of the participants who received psilocybin, and they only saw improvements in 48% of their escitalopram or Lexapro group. So once again, encouraging. So more of the people who received psilocybin experienced improvements relative to the group who received Lexapro or escitalopram. So, once again, that's encouraging, but inconclusive. And so here's what Professor David Nutt over in the United Kingdom had to say. Quote, "These findings provide further support for the growing evidence base that shows that in people with depression, psilocybin offers an alternative treatment to traditional antidepressants." End quote. Perfect. Yeah, exactly. And then he later says, quote, in our study, psilocybin worked faster than escitalopram worked. In our study, psilocybin worked faster than escitalopram and was well tolerated, with a very different adverse effects profile. We look forward to further trials, which, if positive, should lead psilocybin to becoming a licensed medicine, end quote. Yeah, I love that. A different adverse effects profile. Like, for example, people who receive Lexapro, dry mouth, sexual dysfunction, emotional bluntedness. In psilocybin, people were seeing the walls breathe. Anyways, which is not, I don't think it's fair to consider that to be an adverse, effect if somebody knows that they're going to be taking psilocybin. But anyways, I just found that kind of funny. Okay, and then Dr. Carhart Harris, who is the lead scientist on this clinical trial, said, quote, these latest findings build on our previous research testing psilocybin therapy for treatment-resistant depression and offer the most compelling evidence yet to support efforts towards licensing psilocybin therapy as a regulated mental health intervention, end quote. All right, so I can't disagree with either of those statements, right? And frankly, I am excited by these results. This study was hampered by a whole variety of factors, not the least of which being evidently the COVID-19 pandemic, which evidently prevented some of their participants from participating in in the study, but also I have to imagine must have affected the psychological states of the participants in a pretty singular way, right? That wouldn't normally be in effect, right? It's not like it's every year that we have a global pandemic that dramatically changes our lives for the worse, right? These are people who are already suffering from depression, and we know that mental health is going to be a significant concern. It already has been during the pandemic, and it's going to definitely be after we emerge from the pandemic. So there are other limitations to this study, but I'm not driven to suspect that there would be significant differences if those limitations were addressed, right? So it's not even worth talking about them. But so fundamentally, I'm excited. The reason I'm excited is that we're in need of new treatments for depression, right? For all the reasons that I discussed at the beginning, and because we just don't have all that many effective medications available to people, to treat a growing threat to human well-being, right? And so any new tool in the toolbox, the armamentarium that's available to physicians trying to reduce human suffering, psychiatric suffering, is welcome, right? And these are some encouraging results. And, so I'm looking forward to seeing a larger study that incorporates a broader sample of the population that's conducted when there isn't a pandemic plaguing the entire population of Homo sapiens, and, is conducted for a longer period of time. If they could do a longitudinal type of study where they follow people for, maybe many months, maybe years, I think there's a lot yet to learn. But these are encouraging results. Until then, thanks very much for watching. If you dig this kind of discussion, maybe you'll consider subscribing and liking and all that kind of stuff. Otherwise, I will see you next